All right, everyone, today we're going to be talking about reorganization and touching on quality improvement and what that all means to you as you start looking for your future careers within the health services industry. So when we start talking about reorganization, sometimes it has that negative connotation attached to it, but don't be scared at the thought of reorganization. It's one of those things that is naturally and inevitably going to happen. Because like we've talked about several times throughout the course, healthcare is ever changing. It changes day to day, sometimes minute to minute, with our regulation changes, mergers, reimbursement changes, and the different structures that we work through. So it's inevitable that it will happen. So it's important to just start to prepare for it, and how we're going to do that throughout this particular lecture. We're going to really focus on how it'll be when you have to initiate as a future manager or supervisor, administrator, how you need to go about it when you start to have to initiate that reorganization within your department or with your employees. When we talk about strategic change, a lot of different things will necessitate change within our strategies. So we may have leadership change or turnover, changes in our market, medical and medicine advances, technology advances, things like this, and just the nature in general of healthcare, like we said, are just going to necessitate the change and necessitate the change of our strategies that we use in healthcare. So it's important that we remain flexible, we remain nimble, and that we can easily kind of go with the ebb and flow of what we see in healthcare in terms of change. So we have a lot of different terms that were presented over the past couple slides, and it was very term heavy. But when we talk about this, it's important that you understand and are familiar with reorganization vocabulary. So when you start hearing these terms, as you inevitably will in the healthcare setting, you're familiar with them, you know what they mean, and so when somebody tells you that they're going to give you a job enrichment or a job enlargement, you know that they're probably about to give you some more responsibilities and more assignments to your current job and your current job structure. Now, as we start to move into quality improvement, I want to go over, before we get into the next couple slides, just to put it out there, quality improvement is everything in healthcare. As we change, as we grow as healthcare practitioners, quality improvement is paramount to everything that we do in healthcare because we are always changing. And particularly since in healthcare we're going from a fee-for-service based reimbursement structure to a value-based purchasing structure, we're now being reimbursed not on the fees that we provide, but on the quality of care that we provide. And this is, this has caused a lot of change, particularly around the way that we are reimbursed as healthcare systems. So we have to use a lot of quality improvement to make sure that our quality is up to par, not only for our reimbursement, but for our patients as well. We want to make sure that we're giving them the quality care that they both deserve and need. So when we talk about the situation currently in healthcare in regards to quality improvement and the quality of care that is being delivered, when you start to look at these numbers, these are very staggering numbers, and some may not think they're true, but they are very, very true. And a lot of these chronic diseases and the increased prevalence in chronic disease that we're seeing, like diabetes, heart disease, things like that, is due in a large part to behavior change. But we have some factors like limited access to care, and those that are uninsured and unable to receive healthcare services because of their uninsured status, that are attributing to a lot of these rising costs in healthcare that we're seeing. And healthcare, unfortunately, the cost of it continues to rise. So as we see here on the right, we have about the last time it was noted, 98,000 preventable deaths, which we're going to talk about in a minute what that number means and what that means in regards to quality improvement and medical errors. But just understand this is more than AIDS, vehicle accidents, and breast cancer combined. So we're seeing more deaths from medical errors per year than these three different causes of death combined into one. So it really has put our country in this kind of crisis situation in terms of what do we do to prevent these essentially preventable deaths that are caused by medical errors. So how do we know this and how do we know it's going on? We had a couple landmark studies, and if you've taken health systems or if you've been in quality improvement, you may have heard of these, but they came out in 1999 and 2001. And these were both landmark studies that come out from the Institute of Medicine called To Err is Human and Crossing the Quality Chasm. And what these two studies did was really work to identify the major challenges that we are facing as the American health system in terms of errors, in terms of quality of care that we're receiving. Are we meeting the benchmarks? Are we meeting the requirements? So To Err is Human came out first, and then To Crossing the Quality Chasm was kind of the follow-up report to that 1999 report. And like we've talked about several times throughout the course, the health system, the amount of money that we are spending on the health system and the care is continuing to rise. So we spend about 18% of our GDP, our gross domestic product, all the money spent here in the United States is spent on healthcare services. Now, when you compare that out to other industrialized countries across the world, you have countries like Japan, who's very comparable to us, who only spends about 2% of their GDP on healthcare services. And another country comparable to us, Canada, spends about 9%, so about half of what we do on healthcare services. And you would naturally think that since we spend more of our GDP than other other countries on their healthcare, that we would have better outcomes and we would have better indicators in terms of our healthcare status. And unfortunately, that's not true. We do see poorer outcomes when we compare ourselves across different benchmarks and across different indicators to other industrialized countries. So it really, like I said, has put us in this kind of crisis mode as a nation in terms of what do we do to kind of resolve these issues or start to work to resolve these issues that we're seeing. So I'm not going to go over each one of these in detail. There is a video on the next slide that I would like you all to review that will go over these a little bit more. But there are 6 dimensions of quality for healthcare that came about as a result of the previous 2 studies from the IOM that really work to define what the dimensions are. And we have safety, equity, effectiveness, timeliness, patient-centered, and efficiency. And I really should have laid them out on the slide. There's a mnemonic to remember these, and it's just called STEEP, STEEEP. So you could put it in the order of safety, timeliness, equity, effectiveness, efficiency, and then patient-centered to help you remember that concept. But these are the 6 dimensions of quality of healthcare that come out from those landmark studies. And you'll learn a little bit more about them on this next slide. Now I am going to go ahead and play the video here. The quality may not be the best, but you are able to access this video from your individual slide deck. So if it's not, go ahead and pause the lecture here to view this video from your slide deck.
Healthcare providers and institutions seek to continually improve the care they provide. Research describes the process healthcare systems and providers use to improve the quality of their care. The Institute of Medicine's 2001 report, Crossing the Quality Chasm, defines 6 dimensions of healthcare quality. This report and subsequent work highlights the complex nature of quality and also underscores the notion that quality can be defined, measured, and improved upon. Each of the 6 dimensions is distinct, and none is more important than the others. Given these characteristics, any course on the foundations of healthcare quality should focus on specific topics and scholarly fields within each of the 6 dimensions, rather than quality as a composite measure. So let's go over each of our 6 dimensions.
All right, everyone, I'm going to pause it here in the interest of time and keep on moving. But as I said, you have access to this video, so please go in, finish watching it to learn a little bit more about the 6 dimensions of healthcare quality. So as we move on and we continue our talk about quality, we have to understand that not everyone and not every discipline and not every patient's family member is going to look at quality in the same light. So we have a lot of different definitions between our clinical staff and our patients family. Not everyone is going to see quality the same way, and this presents, a challenge for us in healthcare, because what we as practitioners think is quality care and quality processes that are being delivered, we have varying viewpoints, so patients and their families may not see it the same way we do. But we have 3 definitions that we generally accept, or 3 different levels of quality that we generally accept in the healthcare field. We're going to cover those on the next couple of slides. So we have conformance quality, and this is, if you had to rank them in order, this is probably the lowest level of quality. It just kind of meets that standard, that minimum out there. Then you have requirement quality, which is kind of that mid-level where you're meeting customer expectations. But what everyone should strive to achieve is that quality of kind, where you're kind of going above and beyond what your patients, families, what your customer essentially is looking for and needs, and you're working to meet and exceed those national standards that have been set. So we have to first define processes as we continue to talk about quality improvement. And the one thing that I hope you guys remember and get from this, besides STEEP, of course, and remembering those and how important they are to your patients, is that everything we do is a process. If you can't define it in terms of a process, then you essentially don't really know what you're doing if you can't put what you're doing in terms of a process. We see that, outcome errors generally are coming from a break in the process. And unfortunately, what human nature, what we tend to do is blame the person first. But remembering that it's often a process problem, not a people problem. And anytime we have those outcome errors, or we don't reach the benchmarks that we're looking for, or something happens, it's usually due to an ineffective process and not necessarily the person. Very rarely are you going to find where a person is going to be attributed to these more outcome errors. It's more often than not going to be attributed to some kind of ineffective or break in the process. So we have these 5 different terms that we just kind of went through: define, measure, analyze, improve, and redesign. And you may recognize those or associate those with a PDCA, a Plan, Do, Check, Act cycle of improvement. But they're also similar to another concept we're going to talk about towards the end of this lecture that revolves around Six Sigma and how we use that for process improvement. But we generally go through in terms of this define, measure, analyze, improve, and redesign, where we define out the problem, get some baseline measures, analyze it to kind of see what's going on, put our improvement in place, and then redesign it based on what we learned from that analyze and improve phase. So we have a couple techniques that we can use to assist us within quality improvement, and these are the most common ones that you're going to see, so I wanted to make sure to go over them. We have the Pareto principle, which actually comes from a 19th century Italian who just realized that about 80% of the wealth of the country was held by about 20% of the population. So he created this 80-20 rule, and it's almost universal no matter what you apply it to. So we see about 80% of the defects are coming from 20% of the causes. PDCA, which we already covered, and then you have your normative group techniques. Which is almost like brainstorming, bringing a group together and kind of brainstorming different solutions. And I have a visual of a couple different techniques. Up there in the left-hand corner, you'll see that plan, do, check, act cycle of improvement. You may hear it called PDCA. Next to it, on the upper right-hand side, you'll see this fishbone looking kind of diagram, which it's called an Ishikawa or fishbone diagram, that kind of helps you determine what root causes are to an issue that's occurred. Below that in the bottom right, you'll have your Pareto chart, so you can see here about 80% of the issues are coming from 20% of the causes. And then to the far left on the bottom is a run chart where we're looking at trends over time. And each one of these different improvement tools or reports are considered root cause analysis. So we're not just going on the surface and kind of shotgunning this and going to the first cause that we find. We're really doing some root cause investigation into what is actually the cause of things happening so that we can go after and attack the root cause instead of just this surface cause that we may see. It may be a result of a deeper issue. So the next thing we'll look over is quickly is a dashboard, and this is really just your snapshot in time. So you can see here for this particular dashboard on that right hand side, we have a quick glance at our dissatisfied patients. We can see how they're ranking us in attention, listening, and explaining. On the left-hand side, we can see how well we're doing versus charging out and how well we're doing on collecting charges. So you can see this particular dashboard is off all months except March, so that would indicate to us that we need to do a better job at collections, or that we have some kind of break in the process where we're not able to get those collections pulled in. And then again, some physician performance below that and dissatisfied patients based out by practice on the right-hand side. And again, this is just a snapshot in time, so you'll want to refresh this and look at this several times throughout the month or the quarter or the year to just get a pulse on how you're doing as an organization so that you can find these issues when they're small and correct them instead of letting them get larger and larger and larger, and then they become more complex to try and resolve. Now these next couple slides, when you do quality improvement in healthcare, you naturally want to share your results with people across your system. When we do quality improvement and we find a great way to do this process, we want to share that. There's no need to, essentially reinvent the wheel, for lack of a better term. And the best way to do this is through creating and displaying storyboards. And that's what we'll see here on the next couple slides. So you'll see this first one, they've kind of implemented this plan, do, check, act that we've talked about and walked through that process. So we'll look at the next couple slides and we'll end with talking about Six Sigma and Lean. So we're going to end here talking about Six Sigma and Lean thinking, both used in quality improvement, but both kind of taking a different perspective. Six Sigma focusing mainly on how to make things defect-free and delivering correctly the first time products that are defect-free. Lean thinking, just about how we drive the waste out of process and eliminate those waste. And these both came from the manufacturing field. Out of Japan, after World War II, they had to essentially rebuild their society. So they had to be very efficient, very smart about how they did that. And so they come up with these two different ways of thinking revolving around Six Sigma and Lean, and how they were going to efficiently and cost effectively start to rebuild after World War II. And we've kind of taken these and implemented those into other industries. You're going to see lean thinking probably a little bit more in healthcare than you will see Six Sigma, but you may also see Six Sigma. Lean is just used just a little bit more commonly.